Arthralgia and photosensitive rash. Letter of referral. Dear Dr. Miss Chloe Taylor, aged 22 years. I would value your opinion on this nurse who presents with a 6-month history of joint pains and a facial rash. The rash is intermittently present and appears to be predominantly associated with outdoor activities. Clinical examination is essentially normal, but she is particularly concerned about the possibility of systemic lupus erythematosus, SLE, because her mother had cutaneous lupus diagnosed 5 years ago. Is SLE the diagnosis in this case? Yours sincerely. Introduction. The combination of joint pains and a facial rash in a young woman certainly raises the possibility of SLE, more so in the presence of a family history of lupus, as in this case. However, although SLE should be the main diagnosis under consideration, you should be aware of other disorders that present with joint pains and a rash. Viral infection, e.g. parvovirus, may mimic SLE. Dermatomyositis, this may present with arthralgia and a photosensitive rash in the V of the neck and upper trunk. Lyme disease and rheumatic fever, characterized by distinctive skin rashes that appear in association with arthralgia and systemic disease. They should not cause difficulties in differential diagnosis. Psoriatic arthritis. Note that photosensitivity is not a feature of viral infection, Lyme disease, rheumatic fever, and psoriatic arthritis. Each of these disorders has characteristic features that enable it to be distinguished from SLE on clinical grounds. Proceed to serology in cases of diagnostic doubt. History of the presenting problem. Is SLE the explanation? The aim must be to clarify the presenting symptoms, and also to ask relevant questions regarding involvement of other organ systems. Joint pains. Ask about the following. Onset and course of the pain. Nonspecific joint pains associated with early morning stiffness may occur with any inflammatory disorder and will not help in differentiating between lupus, parvoviral infection, and psoriatic arthritis. Distribution and symmetry. Is it proximal or distal? An asymmetrical distal arthropathy may occur with both lupus and psoriatic arthritis, but is distinguished by characteristic distal interphalangeal joint involvement accompanied by skin changes in psoriasis. Large joint involvement tends to occur more frequently in psoriatic arthropathy. Morning stiffness. This is a nonspecific feature of any inflammatory joint disorder. NB. Joint involvement occurs in 90% of patients with lupus and is characterized by asymmetrical, distal, and non-erosive arthritis. Frank deforming arthritis is rare and occurs in a small minority of patients. Rash. Ask about the distribution of the rash. Does it predominantly affect sun-exposed areas of the body? Does sunlight precipitate or aggravate the rash? Skin manifestations of lupus may occur either on their own discoid lupus erythematosus and subacute cutaneous lupus erythematosus or in association with systemic disease. In subacute cutaneous lupus erythematosus, a photosensitive malar rash affecting the bridge of the nose and the cheeks is characteristic. Photosensitivity is a characteristic feature of the skin rash of lupus, which is probably due to the induction of keratinocyte apoptosis by ultraviolet light and the consequent exposure of lupus autoantigens to the immune system. Other relevant history. Since SLE is a multi-system disease, ask about the following pointers to the diagnosis and activity of lupus. Hair loss. Livedo reticularis. Raynaud's phenomenon. Mouth ulcers. Chest or abdominal pain, serositis, and dyspnea. Headaches. Seizures. Drug history. To exclude the possibility of drug-induced lupus, more than 80 drugs have been reported to trigger lupus, with common culprits being sulfasalazine, hydralazine, and minocycline. Plan for investigation and management. After explaining to the patient that under normal circumstances you would carry out a thorough clinical examination to confirm the findings in the referral letter, you would plan to perform the following tests. Immunological investigations. Antibodies to nuclear antigens. As SLE is the main diagnosis under consideration, the patient's antinuclear antibody, ANA, status is crucial. NB. Using human epithelial cells as a substrate. ANA positivity, titer greater than 1:80, occurs in more than 99% of patients with untreated SLE. Negative ANA effectively excludes systemic lupus. As a positive ANA can occur in a variety of other disorders, it is important to characterize its specificity, i.e. is it directed against double-stranded DNA and/or other extractable nuclear antigens, ENA, individual specificities known as RO, LA, SM, and ribonucleoprotein. NB. Antibodies to DNA and ENA are specific for lupus or lupus overlap disorders and occur in 30–90% of patients. Serum complement levels. Check C3 and C4 levels. Patients with lupus may be hypocomplementemic as a result of active disease and/or possession of one or more C4 null alleles. Antiphospholipid antibodies. Check for anticardiolipin antibodies and lupus anticoagulant. These antibodies occur in 30% of lupus patients and act as markers for thrombosis. Other tests. Check the following. Urine, dipstick to check for proteinuria and hematuria. If there is proteinuria, quantitate by estimating urinary albumin and creatinine ratio. If there is hematuria, microscopy of sediment for red cell casts as evidence of active glomerulonephritis. Renal function. Liver function. FBC, looking for cytopenia. C-reactive protein, marker of inflammation/infection. This is often normal in active uncomplicated lupus despite elevated erythrocyte sedimentation rate or plasma viscosity. It would be worthwhile pointing out that further investigations may be required should the diagnosis of lupus be confirmed. If renal function is significantly impaired and/or there is an active urinary sediment, then it is likely that a renal biopsy will be required to determine prognosis and guide treatment decisions. Skin biopsies are seldom performed in the assessment of SLE, although the demonstration of a lupus band is useful in the diagnosis of cutaneous lupus erythematosus. Further discussion. Given the multi-system nature of the disease, the American College of Rheumatology have drawn up a list of criteria to help in the diagnosis of SLE. Although these are helpful for research and disease classification, it is important to recognize that rigid adherence to them in clinical practice may, on occasions, lead to the delayed diagnosis of lupus. American College of Rheumatology criteria for the diagnosis of SLE. Malar rash. Discoid rash. Photosensitivity. Oral ulcers. Non-erosive arthritis. Serositis, pleuritis or pericarditis. Renal disease, persistent proteinuria or casts. Neurological disorder, seizures or psychosis. Hemolytic anemia or leukopenia or thrombocytopenia. Antinuclear antibody. Antibodies to double-stranded DNA and anti-ENA and antiphospholipid antibodies. To establish a diagnosis of SLE, 4 or more criteria are required serially or simultaneously during any period of observation. If this patient is shown to have lupus, it would be worthwhile excluding primary complement deficiency in view of the positive family history. Homozygous deficiency of early complement components, C1q, C1r, and C1s, C4 and C2, is strongly associated with the development of SLE.